Welcome back, everyone. I hope you had a chance to get a beverage or maybe a bite to eat. It's my pleasure to introduce Dr. Helen Leonard, who is going to give us some updates on phenotype cases in CDD. With that, I'm going to just hand it over to Helen to give us an update.
Thank you. Oops. Wait a minute. Can't share my screen. I can't share my screen. Can you hear me? Wait a minute.
Okay, Amanda will
I
help you
can't-
get started in just a second.
Try now, Helen.
Right. Yeah, that's it.
Helen, I can see your screen.
Great. Okay, you can
Yeah,
see
I
it all
can
right?
see it.
Yeah.
Yep, we can
Okay.
see it.
All right, thanks very much. Okay, lovely to be here again. And this time I'm going to be talking about exploring variation in the clinical presentation of CDKL5 deficiency disorder and possible genetic determinants. Now, I'm going to repeat one or two of the slides I had before because some of you may be new to this presentation and may have missed the previous one. But my apologies to those who have already heard it. Anyway, I'm going back to the beginning now, how I became involved with CDKL5 deficiency disorder, as it now is, almost 25 years ago, when I met the family, the mother of these two twin girls here, who, and the one on the right had been diagnosed as atypical Rett syndrome, early onset seizure variant of Rett syndrome. And the girl on the left had been diagnosed with autism. So they joined our Australian Rett syndrome study, at least the one on the right did, and her family. And but it turned out when the MECP2 mutation was identified as a cause of Rett syndrome, there was no MECP2 mutation identified in this family. And so the search was on for something else, which turned out to be CDKL5. And I just wanted to focus on this again on this slide, because I'm going to come back to it, that this was taken in 2004, and now you will see an update in 2020, 16 years later, of these two young women. Just to give you a quick overview, we identified CDKL5 as an independent disorder in 2009, my goodness, when we, no, sorry, it wasn't that, it was 2011, when we used our Interret data and we compared those with mutations in CDKL5, the early onset seizure children, with the typical Rett syndrome who had children who had mutations in MECP2. And we noticed, we developed this table for where we showed the characteristics that were most likely in CDKL5. And of course, as you all know, seizures within the first year, usually within the first 3 months of life, global developmental delay, severely impaired gross motor function, and other features like sleep disturbances, hypotonia, teeth grinding, gastrointestinal issues. Less likely was independent walking and microcephaly, which occurs in Rett syndrome, and major birth defects. Although we did show that the girls and boys did have some similar facial features, which you can see there on the left of the slide. So why in 2012 did we need an international database for CDKL5? We knew it was an independent disorder, but we needed to know much more about diagnosis, natural history, life expectancy. But what I want to focus on is the clinical variation in CDKL5 disorder. So the topics that we cover in our questionnaire are the early period, the pregnancy and birth, the early development, diagnosis, regression, how the child is functioning, mobility, hand function, communication, epilepsy, comorbidities like gastrointestinal, respiratory, scoliosis, osteoporosis, sleep, behavior and mood, medications, hospitalization history, and we asked for some information about the family. So why did we, and still do we, want to study clinical variation? We want to know what the clinical spectrum of this disorder is. Are the children who have epilepsy and severe impairment, they might just be the tip of the iceberg? Well, it might be that CDKL5 mutations cause a much milder disease. We don't know. Why do some children appear to be more severely and others much more mildly affected? Are seizures mandatory? Do children with CDKL5 have to have seizures? And how much do children and adults change with age? And how much of this variation is genetic? And are there other determinants? If we can understand and answer some of these questions, we can provide researchers with clues to how certain genetic treatments or manipulations might lessen the severity of CDD. What as researchers do we need to study clinical variation? We need information from many, many families with children of different ages from infancy to adulthood. We need the same information on these individuals at different time points. We need large numbers in order that we have adequate numbers of children and adults with the same genetic variant. With close on 300 different genetic variants already in our database, you can imagine the numbers that we need in order to have sufficient numbers to study individual variants. So just to remind you here, we have details available for 376 individuals with a pathogenic mutation. And for these 376 individuals, there are 283 distinct, unique pathogenic mutations. So of the 376, recurrent mutations are occurring in only 139 cases, that there is 139 who share the same mutation as someone else. The maximum number per a mutation is 9, and we only have 10 unique mutations which include more than 4 individuals. So you can see the challenge. So what were the ages of the children and adults in our study when the parents filled out the questionnaire? 14% were younger than 1 year, 31% between 1 and 2, 22% between 3 and 5 years, 6 to 16 years, 28%, and only 5% were 17 years or above. Now, many of these families, this was at baseline, many of these families have already been invited to fill out a follow-up questionnaire, which is already providing important information about changes over time. And so working together with families, what data has been collected to date? We've collected data on this unique disorder, as I mentioned before. We've collected data on the variability in attaining developmental milestones, and whether boys and girls are different, whether large mutation groups, whether there are differences. We've also collected information on the functional ability, whether or not they can walk, whether or not they can sit up independently, level of communication, etc. We've collected information about the prevalence and onset of other, what we call comorbidities, medical problems, in addition to seizures, like sleep disturbances, scoliosis, behavior problems, etc. And we've also used our data to study actual CDKL5 variants. So I mentioned in my last talk, but in case you missed it, it's possible to search our CDKL5 database by going to the website that you can see above there, and you can search on particular characteristics of CDD and whether they vary by age group, whether they vary by gender, and whether they vary by the large mutation groups that we have shown. So there's some examples there by sleep and ability to walk below. So as I have said, there's considerable variation in the skills and level of function of children with CDKL5. If you look at the communication here, you can see up to about 20% might either be able to sign or use spoken language. And the equivalent percentage really have very little communication at all. And the remainder are in the middle. We're particularly interested to know why some children and adults are on the move with much less impairment than others. So you can see the two on the top here, about just under 60% are able to sit up independently, with about 22% unable to or requiring maximum assistance. If we go to walking, just over 20% can walk independently, and about 60 to 65% require the maximal assistance or are unable to walk. This just shows you the time to gain various skills like independent sitting. And this varies according to these large mutation groups, which I hope you've seen on a previous diagram. I'll go through them again later. No functional protein, missense mutations, truncations after the AA272 and before AA781, and truncations after 781. Now you can see this pink here, which is the late truncations, the truncations at the end of the gene. They actually learn, these children with these in this group actually learn to sit earlier and are more likely to be able to sit. They do the same with walking. They learn earlier and more likely to be able to walk. And this is called time to event analysis. But it's a very important statistical technique for this sort of analysis. So the frequency of seizures also varies from about 13% here who don't have seizures to about 35% who are having seizures at least 5 times a day. So considerable variation. We already know that those who have, we've shown anyhow, that those who have better functional ability also have better reported quality of life. And this is an example of quality of life in those who have no assistance in sitting compared with those who require maximal assistance. And there are quite marked differences there. Similarly with speech and communication, those who are able to communicate have a much better quality of life than those who are unable to. So now we want to look again at what contributes to the variability in functional ability and seizure burden. So what I want to do now is just show you 3 case studies, and the girls and women involved here, their family have very generously contributed these videos to this presentation. So I'm very grateful to them, and I hope you all appreciate what they have done, because I think they provide some very interesting stories. So the first case is a 29-year-old woman with mild intellectual disability. She can speak in full sentences, read and write, and she can walk, run, and ride a bicycle without assistance. At 2 years, she had a febrile seizure, but she has had none since. However, she's had unusual episodes of periods of altered mental state associated with confusion and repetitive behaviors. And they have occurred intermittently throughout her life at varying intervals and have been of varying duration. So we have written this paper up, and we are very happy to send a copy of it to anybody who would like it, and that's the reference down below. Anyway, she at the age of 29, throughout her life, her parents took her to various medical people, and she had lots of testing done, but were never able to identify the cause of her symptoms. But in last year, she was diagnosed as having a CDKL5 variant. Because she was so unlike CDKL5, we wanted to make absolutely sure that this variant was a truly pathogenic mutation, because there are lots of mutations in CDKL5 that aren't actually pathogenic, that are just normal variants. So was this really pathogenic or was it not? Anyway, we collaborated with a laboratory in Dundee, Scotland, and they looked at this mutation in vitro, and they found that this mutation certainly reduced CDKL5 activity, but it did not reduce it as much as typical mutations. So it's really telling us in vitro that this is a mild mutation, which really fits in with this young woman's characteristics. And let me just show you to her now. So if you look here, she has a beautiful voice. I'll stop there, but I could listen to her singing all day. I love her voice. And just have a look here at her catching some fish.
Look at Lauren catch those fish. Oh, that tickles her. Get it, girl. Get it.
So as you can see, she had a very different phenotype from what would be expected, but I think her story is important. So the second case study is a 12-year-old girl who presented with seizures at the age of 6 weeks, mainly nocturnal. Her seizures ceased at the age of 6. She has not been on any anti-epileptic drugs for the past year and had no seizures. She's fully mobile, she communicates well, and her language is improving every day. She has a CDKL5 variant, and that's it there. It is actually a truncation after AA781. So it's a late truncating mutation. So I now would like to show you a little bit of video of her. We visited her last week, and the family we visited her because we're using her in our pilot protocol to develop a video protocol as part of the study we're doing preparing for clinical trials. So she very kindly obliged, and
good sitting. Good. And now let's go onto a chair. Let's go sit on a chair.
No.
You're standing up.
That's a reward later.
Good girl. Standing.
Reward later.
Yeah, reward later. Sitting on a chair.
Malaka, do it by yourself.
Okay, good girl.
How about do it by yourself?
So you sit down on the chair. Show me how you sit.
No.
Good girl.
Can I have a reward later?
Sitting down.
Can I have a reward, Mum?
Good girl.
Can I have a reward later?
You can have a reward later. Good, well done.
unfortunately, we forgot to take a reward for her, but never mind. She did everything she was required. So here she is again.
Good job, Helen. And do you want to run back to me? Come on back. Nice one. Good job.
So that I'll now move on to case study 3. This is a 35-year-old woman In fact, and her twin sister has typical symptoms of CDD. So she is the woman who, this is the couple that you saw in the first slide, and this is 15 years later. She has never had seizures. She's very healthy. She has a mild intellectual disability, and she's been diagnosed with autism. She is fully mobile. She communicates well, and her cognition appears to be improving with age. She has this CDKL5 variant, which is in the group of no functional protein. So I'd like to show you a couple of videos of her talking with her mum.
How are they going?
Oh, they lost from the Roosters.
Did they?
Yeah.
Oh no, what was the score?
I don't know. I didn't watch it.
Oh, well, that's not good.
We've got the Raiders this weekend,
Oh, okay.
but I can't watch it on TV. Not on TV, I think.
So she was having a conversation with her mum about the National Rugby League matches, which very little of which I know much about. But this was the NRL Premiership between the Roosters and the Parramatta Eels. And I just thought you'd be interested to know, but stop press, that the Raiders actually lost to the Parramatta Eels, and that was the match that this young woman was talking about. So that's the context.
How Para going?
And here she is again. And oops. Oh, sorry.
If I need to go wear sunglasses in the sun, I just have to wear my sunnies.
Yeah, but you wear your other glasses at other times. You should have them on now.
Yeah.
Can you see the television from here?
Yeah. I can see mine as well.
So you really don't need them, you reckon?
So I'll keep them anyway, just in case.
Oh, I guess so.
So you're going to see Ashley?
Yeah, I'll go and say hello to her.
I'll see her during the week anyway.
Yeah, was she good?
Yeah, she's good.
Yeah, that's good.
She's cheeky though.
Is she?
She doesn't like getting her hair brushed much, does she?
Nah.
Or her teeth.
No, I know.
So that was the two sisters that you saw at the beginning of the presentation, and there they are today, 16 years later. So just to look at those the mutations for these three examples. So the first one was a missense mutation, and we have shown that it is causing less of a reduction in CDKL activity than other variants. And I think this is quite important. The second one is the truncation, has a truncation after AA781. So this is this group here, which we have shown in the past seem to have a slightly milder phenotype and more functional ability. And then the last young woman has a mutation which comes into this group of no functional protein. Now, the interesting thing is that her, twin sister has a typical characteristics of CDKL5. They've had X inactivation studied, and there are differing phenotypes cannot be explained by X inactivation. So the cases like these are likely to help us in the long term, but I'm not quite sure what the answer is at the moment. So what about the severity of individual variants? In a recent study, we actually aimed to investigate if the differences in clinical severity can be identified for individual variants. And we also wanted to look and evaluate how well the large groupings that we've talked about before, the A, B, C, and D, or the 1, 2, 3, and 4, which I just showed you, whether there really is, can you make any assumptions about what you find with those. Anyway, the available data that we had for this study was on 285 individuals with CDD, on whom we were able to calculate a severity score. we had 62 with one of 13 recurrent variants, and 49 of these 62 were over 18 months of age. Now, these are this is another diagram of the gene, and these are the recurrent variants that we're going to study. As you can see, they're clustering in this area, in the missense in-frame area within the catalytic domain. There are 2 here in the in area C, the truncations between A172 and A81, and just 1 here for the truncation, late truncating variants. So we used the CDKL5 development score, which was developed by Scott Demarest to assess development. The score is calculated from 0 to 7, with 1 point awarded for each of the following: independent sitting, standing, independent walking, grake and grasp, pincer grasp, babbling, and single words. And higher scores indicate attainment of more milestones. Then we measured severity using an adapted abbreviated version of the CDKL5 clinical severity assessment. You may have heard of that already in a talk by Tim or Scott, and we're actually validating that instrument at the moment. But our modified instrument consisted of 6 domains, which measured epilepsy, motor function, GI and feeding, respiratory, behavior, speech and sleep, and other comorbidities. Higher scores, unlike the CDS, higher scores indicate more severity, and there's a maximal possible score of 83. So we used analysis of variance to compare the severity and CDS scores across age group and across gender. And we compared the severity scores and the CDS scores amongst the recurrent variants and amongst the large groups using multiple linear regression and adjusting for age group and sex. So here are some of our results. So if you look, this is the CDS score, and it's looking at it by age group. And you can see that the CDS score, the development score, is highest in those who are 13 and over. And this is quite gratifying, really, because at least we know it's higher than it is for the 7 to 12. So it looks as if, you know, motor skills continue to improve over time. We also look at severity score, and although it's not significant, we actually find that the severity score is lowest in those over 13 years, which is also a good sign, suggesting that, that children are not becoming more severe with age. We've also compared them in males and females. Now, in our original papers, we thought that males were more severe generally than females, but work by Scott Demarest recently has suggested that this may not be the case. And here we're finding, you know, that males are marginally more severe, but it's not statistically significant. And when we look at the development score, it's similar, with females being better, but not significantly so. Now, this next table shows looking at the severity score and the development score according to the large mutation groups. So if we start down here, I'm looking at the development score, and I'm highlighted here the truncations after AA781, because they have the highest development score compared with the 2.11 for the truncations between AA172 and AA781 is the lowest. But these findings are not significant, but that is the trend there. If we look at the severity score, we actually find that this group, which had the best development has actually got the worst severity. And I believe that this may be epilepsy that's playing this role, that all these children are doing well functionally, their epilepsy perhaps is a problem. So now we're looking at individual variants. And what you can see here, you may not be able to read these, the writing, but the individuals with R134, 550, and P-GLU 55 ARG variant shift 20 are the ones that have got the highest development scores. So they're the children who are doing the best, and they also have the lowest severity scores. If you look here, you find that the variants associated with increased severity include these other ones, and you can see that here, that they are the most severe. So I've shown you these results graphically. We also have them in a table. I don't want to confuse you with figures, but just to show you, here we can see that this mutation here has got one of the highest development scores. So one would imagine that children with this mutation are going to be more functionally able, as are these ones, and these ones there. And most of these results are statistically significant. Then that was for the CDS, the development. If we look at severity, we find that these are the more severe mutations with severity. Oops, sorry. So I think it is interesting that we have actually been able to detect difference in clinical severity and developmental outcomes for individuals with these variants, given that we really still have very small numbers for each group. So we are finding that, consistent with the findings in Rett syndrome, actually when you group them into large groups, as we did originally, you are not seeing the differences that you're seeing the statistically significant differences that you see when you look at individual mutations. So some points of interest. We found that in some cases, mutations that were directly next to each other on the gene could often have quite a different influence on clinical presentation. Another reason for not grouping them as we did originally. We found, as I think I explained to you when you saw the slide, consistent with our previous findings, those with late truncating mutations had better development scores, but they also had worse severity scores, suggesting that although they might be functionally better, their epilepsy may be a challenge. In the severity score, we find that it's the epilepsy and motor domains that contribute most to the total severity score. As I have said earlier, we are actually validating this severity scale as part of our work in preparing for clinical trials. So this severity scale may well change. When we compared males and females, we did not see as great a difference as we did in our earlier study. Now, like I think it was mentioned in Katie's talk yesterday, it is possible we now have an increasing percentage of mosaic males in our database who have a milder phenotype probably than the females. And that is why now we are not seeing the difference between males and females that we saw earlier. So it also appears that the ARG178 codon, which you can see there, it's got different names on this figure, but it's the same mutations, may be a hotspot for missense variants, as these two mutations seem to have especially severe phenotypes. Now, in vitro studies have shown that this mutation ARG178TRP severely reduces CDKL5 phosphorylation. So these in vitro studies are really consistent with what we are seeing clinically. So in conclusion, we hope that our data will be helpful for clinicians and families when trying to provide information on outcomes for children with specific variants. Because it's a question that I often get from families, what does this mutation mean? So we are actually slowly trying to be able to answer these questions. This is very preliminary data. It has not been published yet, but we hope that we're on the way to be able to find out better answers. However, our findings will be strengthened through continued recruitment in the International CDKL5 Disorder Database. This is really important because we need these large numbers. And prospective collection of clinical data to accompany the questionnaire data. And we are working with the ICCRN. And validation of the severity scale and CDS, and we're working towards that as well. So to those who have not yet joined the International CDKL5 database, a message, that your son's or your daughter's data could provide the missing link, which will help us to discover more about the behavior and function of other CDKL5 variants, which in turn may help us on the journey to find new genetic treatments. There might be 2 cases in our database already with the same mutation as your son or daughter, but where there is too few a number to measure statistically. So it is, please just think about that. But every individual contribution adds to our collective understanding of CDKL5 deficiency disorder. And really, we want to thank you all for your contributions. And especially, I wanted to thank today those families who have generously provided video material of their child. So again, to register with the ICDD, either go to the ICFR webpage and go to the spot where it tells you how to register with our database, or alternatively, go directly to our site where you can see the URL below, and sorry, it's such a mouthful, or email me directly at my email address. So this is our registration form. So if you go to that URL, and it's very, very brief. It doesn't take much to fill it in. If you fill it in, then I will give you a call and just find out whether or not you'd like to fill out a questionnaire for your child. Thank you again to the many, many families who have submitted data to our studies, and funding and support from ICFR, the Lulu Foundation, RettSyndrome.org, and NHMRC. Thank you.
Thank you so much, Helen. Thank you for always being such a great partner to IFCR, and for the love and passion you have for our community. It's greatly appreciated.
Thank you,
Yeah,
Karen.
and Helen, I know it's getting close to 2 in the morning for you, so I think I would have thank you for staying up late. But I do have Carol Ann, she says she's huge on the quality of life of a parent and child. She wants to know if you have any advice for families, how they can communicate these changes to research in the medical community.
So all right. So how we can communicate what our findings is, sorry, is that what she meant?
I think she's asking how the families can communicate their changes of quality of life. And I think it kind of gets at the research you guys are doing.
Yeah. Okay. Yes. Yeah. I mean, I think I think we could. I mean, yeah. I mean that's right. Well, probably what we need to do is another study where we measure quality of life a bit later, and we probably will be doing that actually to see whether it changes or not. But she wants to tell us what's happening in her child. Is that right? Which is changing it. Is that what you're saying? she's got information for her child, which she feels has improved her quality of life, and she wants to share it. Is that what you were saying?
I think perhaps she's asking what is the best way for our community to get across to researchers and scientists the importance of that. And
Oh, yeah.
this is just something I'm drawing from that, is the thought of, you know, small changes in our community. Sorry, Samantha's in the background. Small changes make huge differences in the quality of life for our kids. Amanda, is that how you take that as well? Amanda, you're on mute.
Yes, that is it, precisely what
Yes,
she
yeah.
is trying to say. So I think Caroline, Scott answered you there. We'll dive into this a little bit more on the next call.
But, yeah, no, that's.
Let's see, Helen, I do have another question for you.
Yeah, I'm fine, actually. I'm not, I didn't really notice what the time was, so don't worry.
I believe I have one more question from Facebook, and it says, does it not make sense to separate out the mosaic and non-mosaic bowls?
Oh, well, I suppose it does. I mean, yeah, well, I mean, we wouldn't have that many. I think it was 9 or 11% well, we had about 9% overall had mosaicism, but more of them in boys. And I think, as Katie said in her talk yesterday, the mosaicism isn't always described properly in the, you know, in the report, and there might be mosaicism whether it's missed. But if we had bigger numbers, I certainly would look at it. But she's right that it probably is important, actually. I mean, maybe we should look at that. It's not a bad idea.
So one other question, when you search the database, how is someone supposed to know which mutation group their child falls in? My son, I believe, is truncation after 781, but only because I've seen the chart that links exons and amino acids. Right. Also, how do you know if your child has or does not have functional protein?
Right. Well, it's just, have you got copy of, probably Stephanie's paper, the 2015 one, but there's actually a table of all the mutations. I don't know whether it actually puts them into the groups or not, but that might be worth looking at.
We could probably get a tool on the website,
yes,
a pictorial that would help.
That would be good. That would be good. Yeah, that would be good.
I think the table she's referring is Stephanie's.
Yeah,
that she's referring to.
Yes.
Okay.
Yeah, that would be good.
You guys that can see YouTube right now, do you see any more questions on YouTube?
I am looking. I know there was a question that came into the
we lost you, Heidi. I think that
there's a question that came into the regarding the database that came into the email, which hasn't been used very often. So if you don't mind us kind of going back to de-identification and asking that question. I understand that there will be a de-identifier associated with the patient's information in the databases. My question is whether or not the patient's actual name will be visible, identified, released. If it is there a way to disable this so the patient's name won't ever be visible? And I know you can only answer that in the context of what you're working on, Helen.
No, the patient's name, are you talking about linking? So the patient's name won't be visible. It'll be a code, code. Yeah.
The name will not be there. Yep.
Yeah.
But I don't see anything on YouTube, and other than what we were going to talk about related to quality of life and capturing our community for improvements with outcome measures, and the severity scale being completed at the Center of Excellence and its use in clinical trials. And I think we will throw those guys past Scott, maybe.
Yeah, fair enough. Yep, that's good. Yeah.
I agree. I think those will be covered in the next talk.
Yep.
And Scott's talk later.
Yeah, and so, okay, Helen. With that said, I appreciate staying up so late for all of us.
No
Yes,
problem.
the time difference. You are so kind to be so flexible with your time with this huge time difference. So thank you very much.
Oh, no. I'm better at this time than I would be in the morning. So
You
That's
and
a
me
trooper.
both, Helen. That's why we hang out so late at in-person conferences. We night owls.
yes.
Okay, everyone.
Okay,
I
no
Thank you.
Okay, bye.